We have heard in the previous lecture that human microbiome is a very complex system. It contains trillions of bacteria and tens of thousands of bacterial strains, including various viruses, bacteriophages, fungi, etc. It has a strong influence on nutrition, immune system, and metabolism. And we have also heard that the change in composition of gut microbiome, so-called dysbiosis, can lead to various diseases. I will talk in my lecture about fecal microbiota transplantation, which is one of the methods that was mentioned by Dr. Bayer, developed to modulate the human gut microbiome. So what is fecal microbiota transplantation? We probably all have heard about that. Many of us have started to do this method. It's a therapeutic method in which fecal bacteria from a healthy donor are transferred into a patient through infusion of stool, through colonoscopy, enema, nasogastric tube, or by capsules containing freeze-dried material. There are two recognized indications for fecal microbiota transplantation, which include Clostridium difficile infection, either recurrent or refractory to common treatment. And the second recognized indication I will talk about is ulcerative colitis. However, FMT is very broadly investigated, and there are several other indications which are currently under study. These include Crohn's disease, IBS, severe alcoholic hepatitis, metabolic syndrome, obesity, and diabetes, various autoimmune diseases, neurological diseases, and allergies. So, history of FMT. Although there is a lot of talk about FMT in the recent years, it's actually a very old method. Its history dates back to the ancient China, to the 4th century after Christ. In the modern literature, it was first described in 1958 by Eisenman, who used it in 4 patients with pseudomembranous colitis. And the first randomized controlled trial for FMT in recurrent CDI was published in 2013. And in last year, the European guidelines have been published on this issue. In this slide, we also see the evolution of interest of FMT, which is skyrocketing in recent years. So this is a number of published studies, clinical trials of FMT by various clinical conditions. Of course, the major interest is in Clostridium difficile infection. So how is fecal microbiota transplantation performed? First, you have to have a donor, which can be a close relative, or it can be unrelated donor. In some countries, there are even donor banks being established and used. This donor stool is screened for a number of infectious agents. Then, on the day of application or preparation, you add saline, about 250 cubic centimeters to 50 grams of stool given from this donor. You mix it properly, shake and blenderize. Then you filter it through the gauze. You get a fluid which you fill into whatever instrument you are going to use. So, for example, if you are going to use enema or colonoscopy to syringes, and then you deliver it via the selected route. A much faster approach is using a stool bank, as I have mentioned, where all this process is streamlined. You just call the stool bank like you call for a blood transfusion. You get a transplant, and you can apply it to the patient. A very new and modern method is also application of oral capsules from freezed or desiccated material. However, there is a lot of discussion about the optimal FMT protocol. And you can see it in the dozens of trials that every trial uses a different protocol. So there are different methods for donor selection, from spouses, relatives, friends, healthy volunteers. There are even attempts to identify so-called super donors whose stool gives the best result for various conditions. There is a heterogeneity in the number of donors. Some studies use a single donor, another one pool the stool from several donors into one, usually ranging between 2 and 7 pooled donors. And the stool preparation can be fresh, can be frozen, can be collected under aerobic and anaerobic condition, that there is no contact with the air. It's packed after the collection. The patient preparation varies. Some give colon preparation, some give PPIs, some give antibiotics, some not. And the administration I have already mentioned, NG tube, nasojejunal tube, colonoscopy, rectal enemas, and oral dried capsules. And also there is a variation in the number of administrations. And it ranges from 1 to 10 given daily or weekly. So there is a really big area for research in this area, which protocol for which condition is the best. Before I proceed to IBD, where we have experience and I will talk on, I would like to maybe mention some lessons that we have learned from FMT in the trials given for recurrent or refractory CDI. So FMT has emerged as a useful approach for treating the CDI infections, which are either resistant to antibiotic therapy with vancomycin or fidaxomicin, or are recurrent after the therapy. Last year, there was a large meta-analysis published by Dr. Karashi and colleagues, which included 30 cohort studies and 7 randomized controlled trials. And this meta-analysis has shown that FMT has an extremely high clinical resolution percentage. It was up to 92%. It was significantly more effective than vancomycin, about 5 times. There was a significant difference in response between the lower GI delivery, which was more effective, than upper GI, which was less effective. The difference was not that big in CDI, but still was significant, 95% versus 88%. And what was also evident from these meta-analyses that there was no difference between fresh and frozen FMT transplants. And analyzing the adverse events, the serious adverse events were almost non-existent, were very uncommon. Another meta-analysis by Moedi included 10 randomized controlled trials and simply said they found the same. So very consistent, similar results. But they also analyzed the recurrence rate of CDI after FMT, which was only 19%. So these are a couple of slides showing the difference between various protocols of FMT in RCDI. So comparing the efficacy of single versus multiple deliveries, there was principally about 8 to 10% increase of effectiveness when applied more times. When comparing the upper versus lower route of delivery, the lower route was more effective, about 95% clinical efficacy versus 87% clinical efficacy when applied through the upper GI, so capsules or nasogastric tubes. And this is the comparison when using fresh stool or frozen stool. There was principally no difference in the fresh and frozen FMT, either when given as multiple infusions, so 92 versus 93%, or given as a single fresh or frozen FMT, which was 85 versus 68%. Now I would like to proceed to IBD. We all know that microbiome plays an important role in the physiology of GI tract. Inter alia, the enterocytes function depends on the SCFA, not just as nutrient, but also as anti-inflammatory effect. And it is well known that in IBD there is a microbial dysbiosis, which is characterized by various changes in the composition and diversity. We have heard about that in the previous lecture. So there was a growing interest in using FMT also in this condition, and in UC there are several trials I would like to talk about. So the first case was reported by Bennett, who was a patient himself, and he self-administered FMT as enema following a diagnosis of UC. So he had a diagnosis of 7 years. Prior to that, he had been refractory to various medications, including steroids and sulfasalazine, and he had an active flare. After the FMT, he improved. So very quickly, follow-up studies followed by Professor Borody, who is a well-recognized name in gut microbiology, from Helicobacter pylori studies and etc. And he did a study in patients who failed conventional IBD therapy and documented variable periods of remission ranging from 3 months to 3 years. Meanwhile, we have so fast forward 20 years on, we have now a meta-analysis which was published last year by Costello, analyzing 14 cohort studies and 4 randomized controlled trials. So the cohort studies first, they included almost 170 patients, and the overall mean clinical response was 55% when using FMT in UC. The remission was 24%. There was worsening of UC only in 4% and no change in 40%. In those sub-studies that analyzed also endoscopic remission, which we know is very important, this achieved 29%. And this is the second part of the meta-analysis, which looked at the randomized controlled trials, which we know have a higher ranking in the evidence-based medicine. There are 4 of them by Rossen, Moyedi, Paramsothi, and Costello. This is the characterization of those 4 trials, and I would like to point out, especially on the FMT route, on the top of the bottom of the table, FMT route of delivery, which we see that each study applied a different protocol. So the Rossen analyzed the cohort was 50 patients, endpoint after 12 weeks, and he applied the nasoduodenal route of delivery. He gave 2 trials using fresh aerobic stool from a single donor. Moyedi, it was a trial with 75 patients who used enema with 6 treatments using fresh and frozen from a single donor. Paramsothi, 80 patients after 8 weeks, the evaluation delivered through colonoscopy, followed by enema, self-applied, altogether 40 applications, which is a huge number. Frozen stool, aerobic. Costello, 73 patients, 1 colonoscopy, 2 enemas, only from frozen and stool processing in anaerobic way from pooled donors. And here we have the results in ulcerative colitis. The total clinical remission was significantly higher in FMT than in placebo, with the odds ratio of 3.67. And the clinical response was also significantly better with 2.5 odds ratio. Altogether, 50% of patients given FMT improved. And we see another very important thing which underlines the experience from Clostridium difficile, that the first study by Rossen, that is the one that delivered through nasogastric tube, was sort of out of the typical results. It was not effective. It was a single trial that was not effective for remission. So in UC, in contrast to recurrent CDI, the nasogastric route is not considered effective. There is another interesting study which I would like to show. It's a meta-analysis of 9 studies that try to answer the question whether pre-treatment with antibiotics may enhance the efficacy of fecal microbiota. It was published last year, and we see that in 120 patients, the pooled remission following FMT was about 30%, but the remission was higher in those studies that used pre-treatment antibiotics before FMT, and the difference was about 29%, which was significant. A couple of slides about other diseases. FMT and Crohn's disease, we have limited data. There is no randomized controlled trial. There are a couple of case series which showed some improvement, and the question is still out there whether this pilot trials, this pivotal data will be confirmed. Now the last slide, what about FMT beyond recurrent Clostridium difficile infection and IBD? As I have said, there is a great interest in other applications for FMT. These includes both various GI diseases, but also non-GI diseases like chronic fatigue syndrome, Parkinson's disease, obesity and metabolic syndrome, and multiple sclerosis. I would like to show you two studies which have been done with FMT in other conditions. One is for irritable bowel syndrome, which we know is a very common problem. And a couple of years ago, Dr. Pin published two studies. The first one included 13 patients with IBS, which were non-responsive to medical therapies, and they received FMT and improved their symptoms in 70% of cases. The most improvement was in the scales of abdominal pain, dyspepsia, bloating, and flatus. In another study by the same team, the patients with IBS and chronic constipation showed some short improvement in symptoms, which was, however, not that effective in long term. Another study in obesity by Friese et al. The obese patients received a very interesting study, donor stool from lean donors, and they have improved insulin sensitivity, increased diversity of the gut microbiome, and in the sub-analysis, the Roseburia and another butyrate-producing bacteria were shown to be increased. So, ladies and gentlemen, let me conclude. FMT is clearly a highly effective and safe therapy for refractory and recurrent CDI. But FMT has been shown effective and safe therapy also for induction of remission in UC patients. The role of FMT in maintenance of remission in therapy of Crohn's disease and pouchitis still remains to be established. There is an ongoing and growing interest in the broader application of FMT for other diseases beyond RCDI and UC, and there are dozens of studies ongoing to determine if there are benefits both for infectious and non-infectious conditions. However, further studies are needed to clarify the optimal protocol of FMT in terms of donor selection, preparation of transplant stool, route of administration, and number of transplant sessions. Thank you very much for your attention.
Thank you very much for a very interesting presentation, clearly showing how far we are in this field nowadays. And I would like to open the discussion for this presentation. So, yeah. Second line.
Thank you very much for this interesting presentation. My name is Damila Nugmanova from Kazakhstan. And the question is about, are there requirements for donors? And how do you collect this stool from donors? Is it something like forced stool, or it just regularly day by day? You know, like to collect it's not easy, and then just frozen or not frozen after, but how do you recommend, or what is the method now?
Yes, thank you very much. That's a very good question. So the requirements for donors, there is a protocol which includes a list of infectious conditions which have to be included. So typically you do the stool cultures, stool for ova and parasites, you do some serology for HIV, hepatitis, etc., etc., etc. And you have to show that the donor is free from infectious diseases. There are also some other requirements, like he should be free of antibiotic treatment for at least 3 months, etc. It's usually, it's given, for example, in the guidelines from last year, from the European panel of the experts. And then how to collect the stool. There are two ways. When the center starts doing FMT, it usually uses the stool from close relatives. Husband, wife, or children, and they just collect the stool the day before or on the day of transplantation. they put it in the fridge and bring it at the day before the application. The more advanced centers, which sort of have more experience, they start collecting this stool, and if there is some stool left, they just freeze it and put it into fridge, and they can use it for 6 months then. So you're building a database or bank of stools, and it's much more flexible. You can be very fast in your decision when to apply it or not. So this is how it's done.
So I would also like to ask a question. So what is the current experience in Slovakia with the FMT?
Okay, also a good question. We started in Slovakia doing FMT at several centers. The first one was the Clinic of Infectious Diseases in the University Hospital of Bratislava, which has done about 10 FMTs last year for recurrent Clostridium difficile infection. We have started last year our first patient for ulcerative colitis, also University Hospital Bratislava. I know several patients have been applied for alcoholic hepatitis in the Faculty Hospital of Banská Bystrica. So it's slowly becoming available.
So thank you very much. I will pass the microphone to my co-chair, Professor Ivashkin.
Thank you for your lecture. So, sorry, one question.
I'm sorry.
Could you tell us about clinical approaches for differentiation of donors with high immunological potential and donors with relatively low immunological potential?
Yeah, that's an excellent question. I was waiting who is going to ask it.
If such approaches exist.
Yeah, I'm not aware of such an approach. It is well known from clinical experience for trials that when they analyzed, some donors simply gave perfect results and some donors gave no results. But there are also some differences. There is a lot of talk about the Fucibacterium, prausnici in the super donor stools. But I'm not aware of a selection protocol, a prediction which stool is going to be the super donor, the superstar. So the question is still out there.